starting with you, Dr. Suarez.
I think Gaetano was starting.
Gaetano, okay. So these are the H indices and citations for each of our speakers today. So Dr. Biase, who's our first year neurosurgery resident, you can see his H index is 8. Next, most likely up is Dr. Suarez-Meade, H index of 7, and Dr. Garcia, H index of 5. You can see they have a lot of publications despite being very early in their careers. These are their major publications. Okay, Dr. DiBiase, you want to go ahead?
Yes, sir. Thank you for the introduction. Can you all see my screen?
Yes, we see it.
Thank you, Carlos. So this is some of the talks that we gave last month at CNS in San Francisco. And the one I'll be giving today is on erector spine plane block, improves analgesia after MIS, awake spine surgery. And this is work that we did here with Dr. Colantonio, as well as Dr. Q, Dr. Abodi, and especially from anesthesia, Dr. Elliot Boyagi. I don't have any relevant disclosures. So as you probably heard multiple times, there is an emergent interest in lumbar spine surgery under spinal anesthesia to improve recovery after surgery, same-day discharge. And recently, we also started exploring the benefits of bilateral lumbar erector spine plane blocks that has been previously described as a useful regional anesthetic technique to reduce postoperative pain after lumbar spine surgery. So we wanted to see if there are any added benefits of using that for awake spine surgery. Just briefly, this is a study that we did last year on neurosurgical focus, showing some of the benefits, perioperative benefits of awake versus general anesthesia for MIS TLIFs. You can see a reduction in total OR time by 27%, 57 minutes, a significant reduction in procedure time, about 30%. And also patients had better pain scores postoperatively in the PACU, as noted as a mean numeric rating scale pain, as well as the max pain score in the PACU, with same equivalent of opioid utilization in the PACU. Also, something interesting that we noticed is the patient that had surgery under spinal anesthesia ambulated much quicker than patients that had same procedures under general anesthesia. So as I alluded earlier, the goal of this study was to investigate the analgesic benefits of erector spine plane blocks in patients undergoing lumbar spine surgery under spinal anesthesia. We did a retrospective chart review analyzing patients that had surgery under spinal anesthesia before we adopted ESP blocks for awakes, and then also patients that had awake spine surgery with ESP blocks. We collected time in the OR, first pain score in the PACU after spinal were off, pain score throughout post-op day 0, as well as opioid requirements, POMV, as well as length of stay. This is just briefly touching upon our spinal anesthetic protocol. Usually we give some midazolam for pre-medication. Then in the OR, we do the spinal block with a spinal needle introduced, usually between L3-4 and 4-5, one level above the level of planned surgery. And then we inject isobaric bupivacaine in the subarachnoid space. We flip the patient on the Wilson frame, and then we can use some light sedation during the case with IV DEXA and or propofol. So for the cohort that had the ESP blocks, you can see here they were performed after skin closure above the level of the surgical intervention under ultrasound guidance. As you can see here, the trajectory of the needle, the erector spine plane, and then the injection of the local anesthetic. And we utilize 15 ml of 0.5% of bupivacaine mixed with 15 ml of liposomal bupivacaine for a longer lasting effect, for a total of 13 ml per side of ESP block. As far as our results, we had 25 patients in each cohort, and there was no significant difference in baseline characteristic, age, sex, ASA class, BMI, but we did notice that perioperative opioid usage on post-op day 0 was more than double in patients that did not receive an ESP block, and these are all patients that surgery under spinal anesthesia. Also, the first pain score in the recovery was higher in those that didn't receive the ESP block compared to the ones that did. And also incident of nausea and vomiting was decreased in the group receiving an ESP block. So this is just some of our preliminary data that we wanted to analyze and start reporting, but it really starts the points that an ESP block can be used as an adjunct for minimal invasive spine surgery to enhance recovery. And we were able to show that also in patients that had surgery under spinal anesthesia. Our preliminary data suggests that there is a significant decrease in perioperative opioid utilization, lower average pain scores on post-op day 0, as well as a trend towards lower incidence of post-op nausea and vomiting. And we are continuing to enroll more and more patients and comparing to our older cohort to look at any other advantages of this technique. Thank you. I don't know if Dr. Boyage is on the line, or maybe after all the presentations, if there are any comments or questions.
Hey, Dave Miller, I have one. Do you feel that this is mitigating effects of the lumbar incision then across the muscle, or do you think that, what do you think the mechanism of this is?
Yeah, so definitely helping with the muscle dissection and the incision, and especially during the perioperative time, like post-op day 0 when they are in the PACU, and hopefully that will also lead, we are looking at ambulation, if there is any further increase in the time to first ambulation as a result of the decreased pain scores right after the surgery with the block.
Do you routinely do other local measures for those patients in the PACU or in the post procedure? I mean, we ice down our vertebroplasty patients and things like that, but we don't make. I mean, we make a small, obviously just a needle, sometimes multiple needle passes, but we don't make it a full incision. But it's kind of an interesting thing. Do you do anything else with these patients?
Yeah, so maybe Dr. Abode can comment more. Sometimes we do like lidocaine injection right before the closure, other than these ESP blocks, but I'm unsure if they use like ice packs or anything in the pack.
Local measures, yeah. The lidocaine injection, yeah. Interesting stuff. Thank you.
Yes, yeah. So if the patient receives a ESP block, we can't do any other local, but typically there's no routine additional adjunct for pain control given besides the opioid. But in regards to the mechanism, I think majority of the patient's pain after surgery is just that muscle spasms, and I think that block really aids in mitigating that.
You know, I find it really interesting because occasionally in my PMMA augmentation patients, I will get people who have an inordinate amount of post-procedure pain. It's unusual. Most people are significantly better from stabilization of the fracture, so that whatever post-operative pain they have is very tolerable and minimal for them, and it's not a big deal. But I've had a couple patients who I've actually re-CT'd to make sure something, done a CT scan of the spine after, even though I was comfortable with my PMMA augmentation profile, and what I saw intraoperatively, because they had so much pain. And I, in the end, chalk it up as maybe to spasm. Maybe there are one or two patients, especially patients who I put back on Eliquis, that have a significant amount. I've had, significant paraspinal muscle hematoma. So I'm wondering if it's possible to nail veins as you go through there, and maybe I get some spasm of the muscles afterwards in some of these patients because of that. So it's possible. I'm just thinking about this as a possible adjunct, or maybe not for everybody, because I have a more minimally invasive procedure. But in those patients that wake up or come back and complain of a lot of pain, maybe this is some way to get them so that I don't have to admit them. I've actually admitted these people for observation, and usually by 24 hours, they're better and up and around and out. But I'm wondering if it's a similar mechanism, and this may be an answer for us. It's very interesting stuff. Thanks.
Thank you, Dr. Miller. Good job, Gaetano. So I think I'm going to go next. My name is Paola Suarez-Meade. I'm a research fellow at the laboratory. Today, I'm going to talk to you about some of the ongoing work that we are doing in the lab. And these are the differences in cancer hallmarks that we are discovering between the core, non-enhancing core, non-necrotic core and the margin regions of GBM. So as you may know, GBM is the most aggressive form of brain cancer. It has a dismal prognosis of about 15 months on average, and today we don't have an effective treatment for these patients. One of the reasons why we failed to treat GBM is because this tumor has a highly invasive nature, making complete surgical resection virtually impossible and tumor recurrence nearly inevitable. GBM invasiveness is mainly driven by three important cancer hallmarks: migration, proliferation, and stemness, commonly known in this field as the go and grow engines of GBM. Play this video. In regards to migration, we know that GBM cells modify their morphological characteristics to infiltrate the healthy parenchyma through the perivascular spaces and the white matter tracts of the brain. Highly migratory cells represent an important therapeutic target because if we can stop infiltration, we can stop invasion and then prevent tumor recurrence. Recent literature has described the presence of transcriptionally defined cellular states around the tumor that appear to be segregated and contribute to the intratumoral molecular heterogeneity. Other groups have also described that the GBM proteome has niche-specific signatures that are spatially distributed in the tumor, and that this could determine the tumor behavior as well, suggesting that the cells that are in certain areas are in close communication with the healthy parenchyma, just as the infiltrating tumor or the leading edge. As you can see here, infiltrating tumor and leading edge. They could have a specific microenvironment, and they could have a different biology from other areas in the brain, in the tumor. Our group has a long history of establishing patient-derived GBM cell lines. Our model is very accurate as our in vitro data and in vivo data recapitulates what is in patients. As you can see here, if you compare each one of the tumors that we saw growing in our mice, they're pretty similar, have the characteristics of the patients in the MRI. However, in this study that was published a couple of years ago, we failed to take spatial localization of the samples into consideration. For that reason, we designed this study that aims at characterizing the tumor biology depending on where we get the sample from in the brain during surgery, and mainly focusing on the differences between the margin and the core regions of the tumor. Our method is very simple. Dr. Q and Dr. Chaichana use the neuronavigation system and their experience to localize the samples inside the OR, and they give us tumor samples from the margin and from the core. We then take them to the laboratory and apply our protocol for cell line establishment. So we basically know where we're getting the samples inside the OR with the neuronavigation system, and then we establish 2 cell lines per patient, 1 core and 1 margin. For this study, this is ongoing. We have enrolled already 12 patients, and we have successfully grown 7 pairs of tumor and margin cell lines from all IDH wild-type GBM tumors. As you can see here, we have the MRI, the patient characteristics, and the margin and the core cell lines. To test invasion, we carried out Alamar Blue assays, and we're actually doing more assays that are going to give us more results. But with the Alamar Blue, we did not find any significant differences between groups in regards to proliferation. For Stemness, we seeded a sphere forming assay for 2 weeks, and we saw that cells were able to form spheroids in both samples, with a small trend of having bigger spheroids in the margin-derived cell lines. Interestingly, we found under the microscope that cells from the margin demonstrate a more invasive or highly migratory phenotype in these conditions. So some of our spheroids were starting to migrate outside the tumors. To confirm stemness, we carried out a limiting dilution assay that shows in the red line that our margin-derived cell lines have more stem properties, which is in line with what is published in the literature. What is the most interesting about this study are the results in GBM migration. We carried out our classical transwell migration assay, in which we can see that the margin cells have significantly higher migratory properties. We seated in a Boyden chamber the core and the margin and evaluated migration for 24 hours. And we found these significant results. The margin migrates a lot more. We confirmed with these results with a real-time Boyden chamber migration assay that tests impedance of the cells with the Acknowledgements assay, and we got confirmatory results. Margin cells have significantly higher migration, as you can see in the brown and in the green. And we did this for over 48 hours. And we confirmed this with the sphere invasion assay. We did not have any significant differences, but we see a trend towards higher migration in the margin areas. We then moved to our animal model of GBM, where we transfected our cells to express green fluorescent protein and luciferase, and we then injected the cells in the animals. We did not see any differences in tumor growth by bioluminescence, and survival was same among the groups. We sacrificed the animals at 12 weeks post-operatively, and then we did H&E and human nuclease techniques to localize the tumors. Interestingly, the margin cells appear to be more diffuse and have a higher infiltrating nature, which with the cells directing towards the corpus callosum and other samples, as you can see in this one. The tumor core appears to be more round and has a bulky appearance. And this was true for all the animals included in the study. And also the core tumors appear to be bigger. We're still analyzing these results. To conclude, it is important that we take in spatial localization of the samples into consideration for cell line establishment. Here, we did not find any differences in proliferation, but cells from the margin appear to have higher stemness and higher migratory properties when compared to their core counterparts. It was commonly thought that the margin was more invasive than the core in the tumors, but we're actually the first group to establish cell lines from both areas and to prove this in vitro. I would like to thank our team for all the support, and I'm happy to take any questions. Thank you.
So Paola, excellent work. I've often wondered myself why people haven't looked more closely at different phenotypes between the leading edge of the tumor and the core of the tumor. It seems to me that you would definitely have differential protein expression between the two cell groups. Have you thought about, instead of just culturing the cells, just doing a protein or gene analysis immediately after the biopsy, just on the tissue that's removed at the time of surgery?
Yes, that's a great question, Dr. Chen. The literature has shown differences in gene expression and proteins. We ourselves haven't done it. We are about to send some RNA sequencing from our samples, our cell samples. However, we are deciding, we just got the IRB approved to do multi-omic sequencing in margin and core. We're going to do spatial transcriptomics prospectively in 10 patients and also deep proteomics. So more to come in this. But yeah, it's actually a great question.
Oh, that's great. Thank you.
Of course, thank you.
Paola?
Yes, Anna.
Hi. Good morning, everybody. Very interesting study you're doing. It seems like the cells don't really differ too much when they're not challenged. So you see differences in the formation of xenografts and when you challenge them to migrating. I'm sure you're going to do this, but it will be interesting to see how they respond to therapy differently. So like maybe like radiation or TMZ.
Yes, the literature says that the more invasive cells can actually be more resistant to treatment. Yesterday, actually, I seeded a colony formation assay to see if they're different in regards to radiations. Yes. Mm-hmm. And I'm about to do some IC50s for TMC, but I actually need to talk to you to design some of the other experiments. But yeah, I'm also interested in looking into that. Thank you, Anna.
Perfect. Thank you.
Hey, Paola, this is Rodrigo. I have a question. So my question is, do you know if, obviously you have pointed out that the cells in the margin are more prone to proliferate and then migrate. So do you know if there are like any studies on the stress, like conditioning the cells to stress, and then analysis of the migrating capabilities of these cells after? Because I know we have these kind of studies now in like intravertebral discs, so we kind of like we're able to lower the amount of oxygen and all of those kind of conditions. But I was just wondering, it's been a while since I don't do this, but I don't know if there's like any studies like this on GBM cells.
So I myself, I don't do that, but there's a lot of literature saying that cells react to hypoxic conditions and other conditions when you put them under stress. I haven't done that, but in our lab, I know that other people do. But it's actually very interesting. Dr. Q was talking about the use of the bipolar intraoperatively and see if it increases or decreases the migration, which is something very interesting. Of course, like for them, having like the surgery per se is like a stress stimuli. So it would be interesting to see, but I haven't done that.
Thanks so much. Good talk.
Thank you.
All right, I think I'm next. So I'm going to be presenting on a novel wireless battery-free, fully passive, flexible brain implant capable of stimulation and recording. This is some of the work we've been developing recently, and we've filed for IP as well. So in quick summary, there's been ample interest for a long time in neuromodulation as this holy grail that could potentially address a number of diseases from stroke, trauma, epilepsy, and generalized loss of function. And particularly in epilepsy, medically intractable seizures, there's been a lot of advancements with new devices coming into clinical practice and being FDA approved, such as RNS, VNS, and even DBS. But there's a number of limitations with these devices, such as the use of batteries that need to be replaced. That means open surgery every couple of years just to replace a battery, wires that pass through the skull and can, or other structures and can migrate, fail, be the source of infection or bleed. And this has somewhat dampened what was otherwise huge interest. And even then, you see a lot of patients getting these therapies nowadays as an alternative to surgery, for instance, for drug intractable seizures. But there's clearly a need for new approaches to open up space for their use in even other disease states. With this in mind, we partnered with Arizona State University and we developed this new device, which you can see here in a thin film in a silicone base with all the electronics without any wires or need for battery, that can be placed in a thin film that is flexible, which is also an advancement, and placed directly onto the cortical surface, as you can see with our newest patent on a dual graft that is FDA approved, leveraging what is a concept called radio frequency harvesting. And in simple terms, an external antenna emits a radio frequency signal, which is converted into a pulse voltage, and that becomes the simulation signal. And in opposite terms, when you want to record, for instance, a patient is having a seizure and want to detect that, that gets converted into radio frequency signal, and that gets detected by the external antenna. So basically what we've done is placed all the battery and wiring outside of the skull, for instance, in a cochlear-like implant, so that if you need to change a battery, that becomes almost like a wearable, and you don't have to worry about it. So we produced a number of iterations of the device, tested at benchtop, and once we got into something where we were comfortable with, went to murine model, a rat model, and using, before that actually, using HEIPSC cardiomyocytes-derived cells, we wanted to test if our stimulation signal was reliable and if it was also biocompatible. So we use viability of the cells as a marker for biocompatibility. And because cardiomyocytes will beat, we use the displacement as a functional output of stimulation. And what you can see here below is that we produce voltage at our predetermined frequency, very reliably, always at the same voltage that we wanted, predetermined. And you can see above that we produce the intended displacement of the cardiomyocytes, and here in B, just the summary panel with the beats per minute, just summarizing the experiment. I don't include here the viability of the cell just for the sake of time, but cells were viable afterwards, just demonstrating the biocompatibility of our materials and processes. So this in mind, we went then to murine model, and what you can see here is what we developed more recently, where all the electronics were placed within a dual graft, We basically opened a cranial window and we identified a motor representation of the hind limb of the rat. Our concept, it was a proof of principle study. We just wanted to demonstrate that we could, with all the electronics inside the dural graft, produce stimulation reliably. And what you can see here in B is just the voltage being, the pulse voltage being produced at our predetermined intervals, producing an intensity, which is an arbitrary unit for the movement of the hind limb. And I have here just a quick video demonstrating that we were able, once we identified the hind limb representation, to produce movement at our required time lapse. So with this in mind, we also asked ourselves, why could we not also focus on recording, which would really open up a window for potentially use in, for instance, seizure, which is the area which has seen the most advancement. And what you can see here in A is a modified version of our pattern, now with a depth electrode, using the same basic principle. In B, just a representation of one we actually built. In C, its placement in a rat. And once we injected pilocarpine, which is an accepted model for an acute seizure, you can clearly see that we can record a seizure reliably. So in conclusion, we have developed a new brain implant that can record and stimulate in a silicon matrix using a radio frequency emitter. We have demonstrated reliability benchtop, in vitro and in vivo, and we have secured funding now for long-term studies to prove that it is safe with a free moving rat and also in pigs, so we can test a human-ready design. And with that, I'll take any questions. And I'll just like to thank the team and the C grant for funding this work. Okay.
No questions, just a comment. Exciting work. So, what size are you talking about? Can you vary the size? Are you how do you match that?
Yeah, great question, Dr. Miller. So we have done single channel, multi-channel, so you can really tailor it to the needs of the patient. The concept would be, for instance, in the future, if you identify an epileptic foci that has X amount of size, you can produce it tailored for that particular patient. So I don't think there's any limitations to how big or small. I think it's actually harder to do it in rats because, brains are literally tiny,
yeah,
and it becomes really, really challenging. So I think, for instance, now we're developing the porcine model, and that actually becomes much easier because it's much larger. You can have larger antennas and so on and so forth, and even for the surgical placement as well.
Yeah, it's great work.
I don't know if Dr. Chechana is still on the line. That was our last talk, correct?
No,
Yeah.
I think we have another
one more. Oh, okay, we can move on to the next talk then.
Great job, Diogo. It's very interesting. All right. I'm gonna talk again about migration, and this is work that Dr. Guerrero and Dr. Chechana started, and I'm just kind of wrapping it up. So this talk is titled Human Cancer Cells Migrating in the Human Brain Directly from the Operating Room. As we said, GBM is the most aggressive form of brain cancer with a very dismal prognosis, and that it has a very high infiltrating nature, making surgical resection impossible. The role of the human microenvironment in GBM migration has been studied with reductionist systems and incomplete models that do not capture the full picture of what's happening inside the brain. It's like if we study the World War battles in our history books, and we only focus on looking at the soldiers, but not the actual field, the weather, the conditions in which they will be fighting. Our group, these are publications, as I said, by Dr. Chechana and Dr. Guerrero, was the first one to maintain normal human brain in culture for 2 weeks and to establish this organotypic model from healthy brain samples. And here you can see a healthy piece of human brain with injected fluorescent glioblastoma cells. In this study, we used our organotypic model to evaluate invasion and the migratory patterns of human GBM in human brain in vitro. First, we established patient-derived GBM cell lines and transuse them to express green fluorescent protein. We then get the healthy brain samples from corticectomies or from epilepsy surgery directly from the OR, and we cut them into pieces of 300 microns and maintain them in spatial culture for 2 weeks. After a couple of days, we inject green fluorescent protein expressing GBM cells into the organotypic tissue, and we evaluate migration and invasion. Here we demonstrate, this is the model, and we demonstrate that after inoculation, cell migrates successfully into the tissue, and that we can study their properties in a three-dimensional manner. Here you can see the y-axis, the z-axis, and the x-axis. We noticed that these cells were migrating in specific patterns along tubular structures, and these cells were actually attracted to those after inoculation. 7 days after cell injection, we fixed and stained organotypic samples, and we saw that the tubular structures were actually blood vessels, as you can see here in the staining image, in the confocal image. We stained for collagen 4, which is indicative of a blood vessel. Here you can see the same results. Cell migrate, extend projections until they touch the vessel, and then they become completely attracted to them. Interestingly, they stayed at the perivascular spaces and did not go inside the blood vessels, which is what goes in line with the literature. We then focus on the relationship between GBM and blood vessels. As you can see here, cells had a specific speed, but after merging, migration speed decreased and continued to decrease over time as they found what they were looking for. And here, you can see that cells initially migrated with limited directionality and in different directions. And upon contact, cells move faster toward the blood vessels. Sorry. And here you can see that cell directionality increased after the process contacted the blood vessels and then returned to pre-contact directionality once merged. We also found that after perivascular localization, migration was limited along the blood vessels in both directions. The same cell would touch the blood vessel, increase directionality, and go up and down the blood vessel. And the percentage of cells that contact and then continue to migrate along the vessels was 96.8% of all the cells, while the percentage of cells that migrate to the vessel and leave was only between 3 and 6%. In conclusion, our human tumor and human brain organotypic model serves as a favorable system to study GBM migration ex vivo. With this model, we provide a more accurate microenvironment and better representation of human cancer and cell dynamics in the correct microenvironment and cytoarchitecture. We confirm that GBM cells use blood vessels to migrate and that there is a change in the migration dynamics upon blood vessel contact. I would like to thank our team, and this is work in collaboration with some colleagues at the NIH. And I would be happy to take any questions.
Paola, this is Anna again.
Hi, Anna.
Very, very interesting. Have you considered maybe comparing these results on the organotypic with like in the mice, like using cranial windows to see if the cells do the exact same thing on the vasculature in vivo?
That would be great. I don't think we have like capacity to do cranial windows yet. We have the microscope, but I don't think we can do them, but that would be very interesting, yes.
Right, because
the problem with cranial windows and tumors is that you're limited because you need to inject the tumors very like into the cortex. And there you're changing the classical, the classical GBM injection in mice. That's the only limitation, that you cannot go very deep in the tissue.
Yeah, that is true. But on the other hand, you don't need a lot of cells. So if we get that 2 photons to work, that will be really cool to do.
Yes, I agree with you.
Okay. Well, awesome work. Really beautiful. Thank you.
and I apologize. I had got caught away a little bit there. You know, you were talking about, and you've obviously talked before about the chip. You talked a little earlier today about the fact that we haven't really looked at a lot of low oxygen states. It seems like this would be the perfect model to vary oxygenation. Have you thought about using that with your model?
Correct. In the lab, we can put some of the incubators at hypoxia, and then we can see it. We can see different. Yeah, this is actually the perfect model to see that, Dr. Miller. We haven't done it or plan to do so. We're about to publish this as a model, but it serves for a lot of other opportunities. You can also test drugs, radiation.
Yeah, no, it's fantastic. It's really a wonderful platform.
Thank you, Dr. Miller.
Thank you.
All right, I think I have the last one today, right, Andres? I think it is. So thank you, Paola. So I'm going to be presenting on the functional impact of intratumoral heterogeneity in therapeutic vulnerability across enhancing and non-enhancing tumor components of glioblastoma, a paradigm-shifting personalized medicine approach. So we all know, and it has been the topic of discussion actually today, that GBM is quite complex, and part of the reason why it has been so resistant to any introduction of effective therapies has to do with its intrinsic biological diversity. So we've known since 2008 that GBM is driven mainly by three pathways. That's the RTK pathway, a tyrosine kinase receptor pathway, a P53 and RB pathway. However, there's some nuances to GBM that are quite unique, on top of other things such as the blood-brain barrier. One of them being that most often than not, patients are driven actually by the three pathways at the same time. And you can see here, for instance, in the middle panel, each vertical line is a patient, that not only do you have multiple pathways activated at the same time, you actually have multiple levels in each pathway activated. So it really becomes challenging to target this disease with a single target, because if you block one, the other ones just take over and the disease continues to be driven. And more recently, you have here on the right, there has been a lot of interest in intratumoral heterogeneity, as we learn that actually in a single tumor, you have multiple disease states coexisting and cellular states coexisting and being plastic among each other. Here on the left, some relevant work that has been developed recently. This was published in Neuroscience 2020, where there were multiple regions being sampled, namely enhancing and non-enhancing tumor components. And each red circle will represent a circumstance in which at the DNA level, you found a mutation in part of the tumor that you did not find in another part of the tumor, really raising questions about how important it becomes then, the tumor that we leave behind. Because there's been a lot of interest recently in supramarginal resection going beyond the enhancing core. And it really raises a question if what we're resecting with surgery is actually different from what we're leaving behind. And all the drugs we're testing in the lab are targeted towards a cancer that is not the same, the one we leave behind. So with this in mind, we proposed the following workflow in partnership with Panos lab. Using neuronavigation, we collected 2 enhancing and 2 non-enhancing tumor regions. That was taken to the lab. We split in a single cell solution. And from each of those regions, we developed 2 models, as I'm going to go into a little bit more detail forward. And we tested a bunch of drugs that are in preclinical models targeting those known drivers. And we also characterized those tumor regions. We know that we could do this from our experience with a different grant, DR33, where we have sampled the number of patients and we were able to demonstrate we can actually collect tumor from that non-enhancing region. So we're quite comfortable we're going to be able to do it. And we developed 2 models, as I had mentioned, one which is a microcancer, in simple terms a spheroid without a matrix. The great advantage is that it's very fast. So in 2 weeks after surgery, you can have a full report to the patient with all the drug screens. And the BTIC, which is the expertise of our lab, which takes a little bit longer, but it has a unique advantage, which is it's almost a limitless resource once you establish. You can test resistance mechanisms and so on and so forth. So this in mind, we applied for funding, and we were able to do this in a number of patients. And here I just wanted to show you an example of TMZ, the known standard of care. A, B, C, D are 4 regions in a single tumor, a single patient. You have the 2 models, and you can actually see, for instance, for this patient, the whole cancer was resistant to temozolomide, which is in line with some findings that people have found in the literature. This is another drug, a known alkylating agent, lomustine. And you can see that the whole cancer is also resistant, and the BTIC here on the right has more or less the same response as the corresponding microcancer. However, when you look at pimasertib, which is a MEK inhibitor, we found that, for instance, region A has almost a 50% knockout of the tumor, whereas region C or even region D has almost no response, for a delta of 46% at Cmax. And another interesting finding we found was that for the same region, is exactly the same place, we find actually the BTIC having a response, whereas the microcancer doesn't, raising questions about whether or not this is actually the effect of the stemness property and resistance to this particular agent. Here, just a bigger panel. Again, A, B, C, D, 4 regions, 2 drugs, vorinostat and ulixertib. And you see that for some drugs, this is the same tumor, no significant heterogeneity, but for other drugs, an 85.1%, meaning that it almost knocks out the entire cancer in certain places, and it doesn't have any effect in other places. Here, just a bigger picture of one patient, all the drugs we tested, single drugs, we also tested combinations. And you can see that heterogeneity measured by the delta here on the right will range from 3.5%, which is a case in which vorinostat and HDAC inhibitor worked across all cancer. But you have other examples like ulixertib, and you also have idasinutlin, and you have pimasertib, where there is quite a very significant heterogeneity, with certain regions being knocked out and others being completely resistant. This is just a bigger picture bird's eye view now of all 3 patients, 2, 3, and 4, where you can see enhancing, non-enhancing tumor regions. And in dark blue will be strong response, white no response at all, and other shades of blue in between. And you can see that it is a little bit all over the place. So for instance, patient 2 is clearly more heterogeneous than 3 and 4, but even in 3 and 4, for certain drugs, the tumor will be quite heterogeneous. And here in right, just to make it easier to see it quickly, in red, you will have the delta max, meaning the maximum difference between non-responsive and higher response. So in summary, we've been able for the first time that we're aware of to establish tumor models from the non-enhancing region. We've also identified significant inter and intratumor heterogeneity. We've redemonstrated that standard of care has a poor effect on most tumor models. And we have ongoing molecular characterization to try to understand how we can potentially predict which patients will be higher than lower heterogeneity. One thing I did not include here, because our sample size is still small, but that's what we've been observing, is that the heterogeneity doesn't seem to be directly correlated with enhancing status. So that doesn't seem to be a good predictor of where you'll find differences. So clearly there's something else that we need to do to be able to understand that beforehand. But I think it raises an important question for future directions or personalized medicine approach that should incorporate multi-sampling instead of just single sampling. And with that, I'll take any questions, and I'll just like to thank the team and the Fred and C. Catherine Anderson Foundation. Thank you, everyone.
Well, Diogo, that was a great talk, and I think it actually follows Paola's earlier talk very well. My question is, has there been thought about tailoring chemotherapy regimens based on, I guess, heterogeneity of the tumor? So let's say you find that the periphery of the tumor is responsive to drug A and the core of the tumor is responsive to drug B, having the patient go on drug A for a certain period of time, followed by drug B, and perhaps using the same theory for immunotherapies. So looking at protein expression and in the periphery and tailoring immunotherapy for that, followed by a different immunotherapy regimen for the core. So what are your thoughts on that?
Oh, thank you, Dr. Chen. Yeah, that was precisely our thought process. So there's been a number of papers on sequencing alone, and everyone has published on single cell RNA-seq, protein-seq, DNA, whole exome-seq, comparing tumor regions, but no one had really looked at what was the impact of that in drug response, which was our angle to really find out if this means anything or not. And we were not surprised to find that there's a lot of drug response differences. So our thought process right now would be that in the future, if you were to find if you want to find a drug that works for that patient, we would have to have either, as you mentioned, a drug that would work across the whole tumor. That would be the ideal scenario. And we are most certainly going to only find combination regimens. I think it will be hard to find a single drug, but potentially you could also have, a crossover study where you knock out the majority of one drug and then you use another one to knock out the rest. And I didn't show that, but we're working on combination therapies because there's not a lot known about which combinations will work. It's a little bit of a gray zone. So we're trying to see if we can use this information to then tailor-made combinations that will potentially knock out the entire tumor all at once. Thank you, Dr. Chen.
Yeah, I mean, I think it'd be ideal, obviously, if you could find just one combination of drugs, or one drug that would work across the tumor. But I wonder, with the intratumoral heterogeneity, if, you need to kind of break that up sequentially, right? So attack the periphery of the tumor, followed by the core of the tumor, and not just throw everything at it all at once. And that may also potentially cut down on the drug toxicity as well for patients. But that's, yeah.
Sorry, I was just going to say, and the other thing that I think would also be interesting thought process is that if we are able to resect all the enhancing core and all we leave is the non-enhancing, and that has a different response from the enhancing core on which we found an X, Y, and Z drug response, then potentially what we will give the patient is not what we found on the core, is what we found in the non-enhancing margin, which is what we leave behind. And I think that was also kind of our potential thought process. The only caveat we've found is that we haven't found a marked difference between the drug response at the non-enhancing versus enhancing. It is a little bit hard just with imaging to predict where you'll find those subpopulations that will have a different response.
I have a question, actually. What is the logic behind doing sequentially between the core and the periphery? I'm not getting that part. Maybe I don't have enough knowledge to understand that concept.
Are you referring to my question?
Yeah.
This is just a thought, and I don't know that there have been any studies to back it up, but potentially the periphery of the tumor acts, as a protective barrier for infiltration of various chemotherapeutic agents, or if you're using immunotherapy and the immunotherapy is targeted to the core of the tumor but doesn't actually impact the periphery, then it doesn't get to where it needs to go. So that's just my thought, kind of breaking down the periphery before attacking the core, and that's just very general thought process, and
Okay.
not necessarily anything that's based on any any previously published reports.
I didn't know about this, and I was like, it's something that I should be aware. So thank you for clarifying. Thanks.
Just my own personal ruminations, nothing based in actual literature.
Yo, quick question. Great talk. Do you chose your drugs based on a cancer panel or for from clinical trials for GBM?
Yeah, great question, Paola. So what we did was we looked at the main pathways that are known for GBM. We looked at all the drugs that are available for different targets across those pathways. We tried to select for only brain penetrant drugs because, hopefully if you're going to bring to the patient, that will be the first place to start. And then, of course, we also had to be conditioned by what is available. Some of these drugs you really cannot obtain. They're just restricted to the clinical trial. But that was kind of our process to get to this drug library.
I see. That's great. Thank you.
Absolutely.
Okay, I have another question for Diogo, if there's still time. Do you have enough cell material after you do the first screening to test combination therapy on these cells, or would you have to go on to the cell lines?
Yeah, great question. So that's our first patient was really like our testing ground to figure out how much we need to do all we wanted to do. So at this point, we were quite comfortable collecting enough in the OR, roughly speaking, to be able to do also combination therapy. I think the greatest limitation of the microcans will be if you want to understand why it works or doesn't, if you want to do resistant lines or generate, resistant models to then test it, why. I think that will be hard to do. And that's where potentially you have to go to the VTIC for sure to do that.
Perfect. Thank you.
Thank you, Anna.
I guess those were all the presentations we have for today. If anyone has any other question, then we can just conclude our
just a comment.
series.
Really nice work by lots of people. Thanks, and really impressive presentations. Thanks for filling us in on what you guys have been doing.
Thank you so much, everyone. Have a nice week.